This is Dr. Gardner, and I will be lecturing on chronic obstructive pulmonary disease, also known as COPD. The objectives for this lecture are to describe the pathophysiology of COPD, discuss the rationale drug selection for patients with COPD, and describe the monitoring and patient education required for patients with COPD. We'll also talk about the management of chronic obstructive pulmonary disease, the pathophysiology, the goals of treatment, rationale drug selection, monitoring, outcome evaluation, and patient education. So, what is the definition of COPD? Chronic obstructive pulmonary disease is defined as a heterogeneous lung condition characterized by chronic respiratory symptoms. These symptoms can include dyspnea, cough, sputum production, and exacerbations due to abnormalities of the airways like bronchitis and bronchostasis, and or alveoli like emphysema that cause persistent, often progressive airflow obstruction. The disease occurs when a genetically susceptible patient is exposed to certain environmental triggers over their lifetime. So again, they may have some cough, some shortness of breath, increased sputum production, and of course, chronic exacerbations. Some of the risk factors for COPD include smoking and environmental exposures. Tobacco smoke is the primary risk factor, but exposures to other toxic particles or gases are also risk factors. So, how do we manage COPD? We follow the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, guidelines. The GOLD has published comprehensive guidelines for the management of COPD since 1998. The report is updated yearly and provides the clinician with a solid framework to care for patients with COPD. The diagnosis of COPD should be considered if a patient has persistent shortness of breath, a chronic cough, or recurrent sputum production. And a lot of times these patients will complain of increased sputum production early in the mornings. This should be considered especially with a history of smoking and recurrent lower respiratory tract infections. However, the GOLD guidelines consider spirometry testing with a post-bronchodilator forced expiratory volume in 1 second, forced vital capacity, which is the FEV1 FVC ratio of 0.7. That is mandatory to confirm a diagnosis. So what are you looking at as a clinician? Your patient comes in and they're complaining that they're always short of breath. They have a lot of sputum and they're a smoker. So you suspect they may have COPD. So to confirm, you have to have spirometry testing. And the FEV1 FVC ratio of 0.7 is mandatory to confirm your diagnoses. So what you're looking at is the severity of airflow obstruction chart. Once a diagnosis of COPD is made, the GOLD guidelines recommend grading the severity of the airflow obstruction based on the post-bronchodilator FEV1%, of predicted. So mild would be an FEV1 greater than or equal to 80% predicted. Moderate is 50% less than or equal to 50% or less than 80%. Severe is having less than or equal to 30% or 50% FEV1. And very severe is someone with FEV1 less than 30%. This grade may be adjusted over time as lung function further declines. So someone may start off as mild and progress to very severe. Using standard terminology helps healthcare providers communicate effectively about the condition and the prognosis of the patient with COPD. Before beginning medication treatment, GOLD recommends assessing exacerbation history and symptoms to assign the patient to a group to guide initial choice of medication. Group A has few exacerbations and mild symptoms, whereas Group B is more symptomatic. Group E has frequent exacerbations. So, patients are divided into the following categories based on exacerbation history: either 0 or 1 moderate exacerbation, that's not leading to hospitalization. However, 2 or more moderate exacerbations or greater than or equal to 1 leading to hospitalizations. Once both the exacerbation history and the symptom score are determined, the patient is assigned a group based on their answers. View Table 32-1. This grouping can be used in selection of initial therapies, which we'll discuss later. In the past, patients with COPD were often categorized as having emphysema or chronic bronchitis. These labels are no longer used. The GOLD Workgroup has proposed some new taxonomy to describe some distinct variations of COPD, including the following. COPD-G is a genetically determined COPD, whereas COPD-D due to abnormal lung development. COPD-C, the COPD is due to cigarette smoking, and COPD-P is due to biomass and pollution. COPD-I is due to infections. COPD-A is due to asthma, and COPD-U is of unknown cause. The symptoms are Modified Medical Research Council Dyspnea Questionnaire is scored 0 to 1 or greater than or equal to 2. There's also a COPD assessment test, which is also known as CAT, and that is scored as either less than 10 or greater than or equal to 10. So let's talk about the pathophysiology. In patients with COPD, there appears to be an amplified inflammatory response to airway irritants such as tobacco smoke. The inflammation leads to airflow obstruction and gas trapping. So acute and chronic inflammation, that leads to airflow obstruction and gas trapping. In patients with COPD, airflow resistance is increased in the small airways, and the lung parenchyma can lose elastic recoil, leading to hyperinflation and reduced ability to empty the lungs. Changes in the alveoli and pulmonary circulation can cause pulmonary gas exchange abnormalities or pulmonary hypertension. Viral or bacterial infections often trigger exacerbations in patients with COPD, causing increased inflammation and mucus production. Now, there is an asthma and COPD overlap. There's been debate for a long time about the existence of a unique disease process for patients who have both asthma and COPD. So yes, a patient with COPD can have asthma. Gold first classified a separate entity called asthma COPD overlap in 2015. However, by 2020, it had dropped the distinction, instead considering the two processes as separate but potentially coexisting disease processes. For a patient to be classified as having asthma COPD overlap, all three major and at least one minor criterion must be met. So for major, it has to be a persistent airflow limitation, smoking at least 10 pack years, 10 or equivalent air pollution, and a documented history of asthma prior to age 40, or bronchodilator response, which is the BDR, of greater than 300 milliliters in FEV1. Minor, at least one must have been met. A history of atopic disease or allergic rhinitis, a BDR of FEV1 greater than or equal to 200 milliliters and 12% from their baseline, and a peripheral blood eosinophil count of greater than or equal to 300. Regardless of the controversy about labeling, the sources do agree that patients who present with symptoms consistent with both asthma and COPD should generally be managed according to asthma guidelines. Although not common, one important subtype of COPD is alpha-1 antitrypsin deficiency, or AATD. Patients with this form of disease have a genetic mutation in the SERPINA1 gene that causes a deficiency of alpha-1 antitrypsin, which inhibits serine protease. AATD is an autosomal recessive disease, meaning the person must inherit a mutation from each parent. The genetic mutation in the SERPINA1 gene, COPD symptoms at a young age. Symptoms are similar to other forms of COPD, and it requires augmentation therapy with an alpha-1 antitrypsin product to slow the rate of lung damage. So what are the goals of treatment? We want to slow the disease process, maintain the patient's quality of life. Definitely we want them to stop smoking. We want to prevent infection because infections cause exacerbations, correct? We want to make sure they receive optimal nutrition and receive pulmonary rehab to improve lung function. The major goals of treatment with COPD are to slow the disease process and maintain their quality of life. And although medications such as bronchodilators, corticosteroids, and antibiotics are part of the treatment, there are some non-pharmacological measures that have just as much impact. Stopping smoking is a major impact for these patients. Using the groups discussed earlier in the GOLD guidelines, again refer back to Table 32-1, the clinician can select an initial therapy based on the patient's exacerbation history and symptom presentation. So for patients in Group A, they have few exacerbations and mild symptoms, so the drug of choice is typically a single long-acting bronchodilator agent. For patients in Group B who are more symptomatic but still not having frequent or severe exacerbations, we're going to use the combination of two long-acting bronchodilators. That's recommended in initial treatment. With the updated GOLD guidelines, all patients who have frequent or severe exacerbations are in Group E, without regard for level of dyspnea. In this group, the use of combination or two long-acting bronchodilators and the possible addition of an inhaled corticosteroid are recommended, especially for patients with elevated blood eosinophils over 300. The ATS clinical practice guideline varies slightly on the addition of an ICS, only recommending an ICS for patients with frequent exacerbations. Review Table 32-2 for commonly used maintenance medications in COPD. Bronchodilators are the mainstay of pharmacological therapy for COPD patients. They treat the reversible component of COPD and maximize airflow by relaxing the airway smooth muscle and improving lung emptying during tidal breathing. Three types of bronchodilators are used in COPD management. So beta 2 agonists, those are long-acting beta 2 agonists, are also LABAs. LAMAs are long-acting muscarinic agents, reduce exacerbations and improve symptoms. Initial therapy is a combination of both a LABA and a LAMA. Inhaled beta-2 agonists have been the mainstay for COPD therapy for many years, and though still useful in the acute episodes for patients with only occasional dyspnea, the regular use of a short-acting beta-2 agonist in patients with persistent symptoms is no longer recommended. Instead, the long-acting beta-2 agonists, or the LABAs, are preferred for routine bronchodilator therapy. With a higher affinity for the lipid bilayer of the cell compared with more hydrophilic SABA molecule, the LABA provides longer bronchodilator effects. This helps to prevent symptom breakthrough as the SABA effect wears off after a few hours. Like SABAs, the short-acting muscarinic agents, or SAMAs, are no longer first-line therapy for most patients with COPD. However, the long-acting muscarinic antagonists, or LAMAs, have become a key player in COPD management. These drugs work by binding M3 muscarinic receptors, blocking the effects of acetylcholine on the airway smooth muscle, which results in bronchodilation. These drugs are typically well tolerated and have been shown to improve symptoms and reduce exacerbation. The preferred choice for initiating therapy for most patients is a combination of a long-acting beta agonist and a long-acting muscarinic agent. This combination results in improved lung function, decreased dyspnea, and reduced rates of exacerbation. Now there's also methylxanthine, which is theophylline. Theophylline is not recommended unless the patient can't obtain or afford other treatments. Corticosteroids have non-specific anti-inflammatory activity at multiple points in the inflammatory process. Because the airway changes at the cellular level that define COPD, the effects of corticosteroids are less dramatic in COPD than those seen in asthma. Yet, corticosteroids are key components in the management of stable COPD and COPD exacerbations. Inhaled corticosteroids are combined with LABA and LAMA, and these can reduce exacerbations. Oral corticosteroids may be useful in short-term treatment of acute COPD exacerbations. The oral corticosteroids shorten recovery time, improve lung function, and decrease hypoxemia during the exacerbation. And then there is the phosphodiesterase 4 inhibitors, or PDE4. These inhibitors inhibit activation of the PDE4 receptor sites located in the smooth muscles of the airways, resulting in bronchial relaxation and a decrease in the activation of the immune response. As an oral therapy, roflumilast has increased side effects compared to inhaled therapies for COPD. The most frequent side effects are diarrhea, nausea, reduced appetite, weight loss, abdominal pain, sleep disturbance, and headache. Several studies demonstrated a benefit for the use of prophylactic macrolide antibiotic therapy in reducing the exacerbation rate in patients with COPD. Preferred regimens include azithromycin 250 milligrams once daily or erythromycin 250 milligrams twice daily. Azithromycin 500 milligrams given 3 times a week or erythromycin twice a day. There may be less benefit in patients who continue to smoke. Long-term use of azithromycin has been associated with bacterial resistance, so we have to be careful of that. Prolonged QTC interval and reduced hearing. So you have to outweigh the risk versus the benefit in these patients. During an acute exacerbation, antibiotic therapy may be helpful for some patients. The GOLD guidelines recommend the use of antibiotics only in the following situations: patients with increased sputum purulence and an increase in dyspnea and/or increased sputum volume, patients who require mechanical ventilation support. A short course of 5 days or less is recommended. The choice of antibiotic therapy should be based on local resistance patterns, so you have to know the local resistance pattern for your area. Empirical therapy may be achieved with augmentin, a macrolide, or a tetracycline. For some patients, home oxygen therapy is necessary. Oxygen therapy can be used short-term during acute exacerbations. It can be used long-term in chronically hypoxemic patients. The goals for supplemental oxygen therapy are to correct arterial hypoxemia and prevent secondary organ damage. Ideally, oxygen saturation should be greater than 90%. In patients experiencing an acute exacerbation of COPD, oxygen saturation less than 88% is an indication for short-term supplemental oxygen. Patients should be started on continuous oxygen therapy if they demonstrate persistent hypoxemia at rest. So that's less than 55 millimeters of mercury or less than 88% O2 sats. These patients should be monitored to determine when oxygen therapy can be discontinued. So just because they're started on oxygen does not mean they will always have to be on oxygen. And that's important to relay to your patients. Some patients are very fearful that if you begin them on oxygen, they'll never come off, and that is not the case. For the chronically hypoxemic COPD patient, continuous home oxygen therapy for 15 hours or more per day is associated with an increased survival rate in patients with severe airway obstruction. Patients on continuous oxygen therapy should be reevaluated in 2 to 3 months with follow-up oxygen saturation measurements. So remember, don't start them and forget that they're on it. You have to reassess. Now, COPD therapies in alpha-1 antitrypsin. Remember we talked about that? Augmentation therapy used in patients with genetic alpha-1 antitrypsin deficiency. They may use prolastin C, Aralast, Zemaria, or Glacia, and that is administered IV weekly. You're also going to refer these patients to a specialist for therapy. So if your patient has the alpha-1 antitrypsin, you're going to refer that patient out. And you'll learn more about this if you're in family practice when you get to your family practice clinical setting. Infection prevention is essential in management of patients with COPD, and vaccinating them against any respiratory infections is an integral component in preventing illness. So definitely want to make sure the patients are receiving their influenza vaccine between October and January. You want to encourage these patients to get the SARS or the COVID-19 vaccine. They need a pneumococcal vaccine, 1 dose of the 20-valent pneumococcal conjugate vaccine, which is the PCV20, and Tdap and zoster vaccines are also recommended. All of their vaccines are going to be recommended according to the current vaccine guidelines. If the PCV20 is given as the initial vaccination, the series is considered complete. If the patient received a previous dose of PCV15, a dose of the 23-valent polysaccharide vaccine, which is the PPSV23, should be administered at least 1 year later to complete the series. So remember, it's only 1 dose if they receive the PCV20. Smoking is a major contributor to COPD. Cigarette smoking results in severe destruction of lung tissue, and the damage is largely irreversible. To halt the progression of COPD, the patient must stop smoking. Patients with COPD must stop smoking. I'll say it again. Patients with COPD must stop smoking. Smoking cessation benefits include ventilatory function, returning to a nearly normal age-related rate. So routine monitoring of patients with COPD is essential for optimal disease management. Clinicians must assess symptoms, exacerbations, adherence to therapy, effectiveness of the treatment plan, smoking status, and lung function at routine intervals. Again, you're going to assess for symptoms, exacerbations, adherence to therapy, effectiveness of the treatment plan, smoking status, and lung function when you see this patient in the clinic. You're going to assess their symptoms. At each clinic interval, the history of the patient's symptoms should be taken. The clinician should inquire about sputum production and quality, frequency of cough, the level of dyspnea and fatigue, activity limitation, sleep patterns. You can use the CAT or the MRC questionnaires discussed previously, and that can help quantify the symptoms and slow trends over time. You want to monitor exacerbations. The frequency and severity of their exacerbations is important to the overall treatment plan. Note the level of treatment required, including any hospitalizations. Adherence to prescribed treatments at each visit. You should review the treatment plan and inquire about adherence to the prescribed therapy. Patients often do not continue to take inhaled therapies as prescribed, often because of the cost. So also make sure they know how to use their inhaler. Don't just ask, have them do a return demonstration. It's important to know if they know how to use their inhaler. It's critical for adequate delivery of the medication to the lungs, and it should be assessed and reinforced at each visit. The presence of any side effects of the prescribed therapy should also be evaluated. Assess your need to adjust your management plan based on the previous symptoms, exacerbations, and adherence to prescribed treatments. Assess their smoking status at each visit. You may sound like a broken record, but remember, they must quit smoking. Measurements of their pulmonary function, and you want to assess their quality of life at each visit. Patient education should include a discussion of the information related to the overall treatment plan, as well as specific to the drug therapy. They need to know why they're taking the drug, and that the drugs are a part of the total treatment regimen, and make sure they're adhering to the treatment plan. If not, you have to assess why they're not. Patient education for this patient centers on maintaining optimal pulmonary function and quality of life. Teaching self-management is the basis of successful treatment. So remember, you're going to educate them also on the pathophysiology of COPD and make sure they know how to use their inhalers properly. Just prescribing an inhaler is not enough. Have them come back with that inhaler and show you that they can use it. COPD mortality is expected to exceed 5.4 million per year by 2026. So effective pharmacological interventions can prevent COPD exacerbations. Teaching them self-management skills will promote a more successful outcome and a better quality of life. Have them bring all their medications to each follow-up visit. Provide written schedules in divided pill boxes. Make sure that they're following the dosage and schedules for taking their drugs. Make sure they're adhering to the treatment plan and that they're receiving their vaccines. And that is it for your COPD lecture. If you have any questions, don't hesitate to ask.